chairperson in Egypt. His talk will be about osteoid, osteoma. What shall I do?
Thank you, Mr. Chairman. I'd like to thank the organizing committee for the kind invitation. I will cover the other side of the page, the benign tumors, unlike my previous speakers. Osteoid osteoma, it is a benign bone-forming tumor, usually composed of nidus, which is a loose fibrovascular stroma surrounded by radiodense reactive thickened bone. It can be seen in the dorsal spine, or in the lumbar spine, in the cervical spine, and rarely in the sacrum. Of course, you can pick it with your eye in the plain X-ray, and it is usually less than 2 centimeters ovoid lesion, and in the CT, it will delineate more the nidus and the surrounding sclerosis. It is usually present in the posterior element, and of course, CT scan is the modality of a choice to investigate your patients. MRI is helpful, and you can pick that at T2 signal, there is hypo-intense signal intensity surrounded by bone marrow edema. In T1, you can find intermediate signal intensity lesions because of the calcification. Of course, you can use the technetium bone scan to delineate the lesion, like this patient with a painful scoliosis and lesion in the concave side of the curve. Usually, there is a typical focal uptake with double density sign, central focus intense uptake surrounded by lower increased uptake. Back pain is the most common symptoms, and of course, it improved by giving the patient non-steroidal anti-inflammatory drugs at night. Because the osteoid osteoma, the nidus tend to release prostaglandins, which stimulate the nerve ending inside the lesion. But other symptoms may occur like radicular pain, gait disturbance, limb atrophy, and painful scoliosis. The differential diagnosis are many types of other pathologies like osteomyelitis, but of course, the laboratory investigation will show that there is increased ESR, C-reactive protein. The total leukocytic count may be increased as well. Osteochondroma has differential radiological picture. Osteosarcoma, of course, is a very aggressive and other radiological pictures. Bone island or localized bone thickening. Localized bone thickening can be seen in some cases like this case. For example, we have here dense sclerosis in the contralateral pedicle in a case of lysis. So the contralateral pedicle, there is increased stresses and there is increased or compensatory hypertrophy inside the pedicle. Or sometimes you can have stress fractures and it can lead to cortical thickening. So these are very two common differential diagnoses and can be seen in teenagers. Of course, to do a biopsy in bone tumors, it is recommended to know your enemy before any intervention. But because of osteoid osteoma is a benign and it has special radiological pictures that you can push you toward the proper diagnosis from the radiology and its size, which is less than 2 centimeters, and the surrounding of dense cortical bone. So most of these cases, you don't need to go for biopsy. And the treatment options will be either conservative, relying on giving your patient non-steroidal anti-inflammatory drugs to decrease the amount of prostaglandins released around the nerve ending inside the tumor. Thermal destruction, of course, is helpful, either using laser, HIFU, which is to introduce photocoagulation of the lesion, or radiofrequency ablation. But in my country, these actually interventions is much costly when we can compare it with surgical excision. And also, radiofrequency ablation needs special technical methods to dissect the neural structure to be put away from the lesion, like using pneumodissection or hydrodissection using the glucose xylocaine. And of course, you can apply the probe to release a lot of radiofrequency waves that create 90 degrees Celsius temperature for 5 minutes which can cause destruction of the tumor. But it is recorded in the literature that the recurrence rate may reach up to 16%. I will show you some cases that I dealt with. For example, this is a 23-year male. This lesion is common in males, complaining from mild intermittent low back pain for a long time. It becomes more constant and severe at night. This is the typical complaint. The pain reduced by non-steroidal anti-inflammatory drugs, which is known as salicylate suppression test. No history of trauma, not relieved by rest. Early, it is vague, then increase in severity and become aching in character and interfere with the patient daily life activity. We can see here in the plain X-ray there is something lower down in the L5S1 facet. It is a little bit hypertrophied, but as we said, CT scan is much helpful to pick up the lesion. We can see here the lesion in the inferior facet of L5, and of course you can pick also the pathology in the MRI by the presence of area of hyperintensity. Of course, this patient tried to take the non-steroidal anti-inflammatory drugs, but he didn't improve, and we decided to operate upon him. Going for radiofrequency, it is a little bit close to the neural structure. The lesion here in the superior facets, there is no 5 millimeter safety space, plus the cost of doing radiofrequency. And I can do it microscopically by drilling this part by the high-speed drill. And this is the post-operative CT, and this is the lesion, I get it, and this is the result of the pathology, which prove it is an osteoid osteoma, and the patient post-operative is highly satisfied. Another case is a 18-year-old patient with mild intermittent buttock and back pain, becoming more constant and severe at night. The pain reduced by non-steroidal anti-inflammatory drugs, so it is the same typical complaint for osteoid osteoma. No history of trauma, not relieved by rest, and it become aching, normal range of motion, completely normal regarding the neurological examination, and this patient has sacral tenderness. Of course, the plain X-ray will not help. The laboratory is very favorable, but the CT scan was delineating the lesion. We can see the lesion is here. The lesion is here. We can see the dense sclerosis and the nidus. So for this patient as well, I decided to go and do in block resection of this osteoid osteoma, and I was able to get rid of it. And this is the immediate image intensifier X-ray for this, showing the void of the lesion, and post-operatively the patient was happy. And I searched in the internet what is published regarding osteoid osteoma in the sacrum, and I found it is only 19 cases was published in the English literature. So my case is the 20 case in the literature. This is another case. It is 10 years old child with painful scoliosis, and we can pick here the osteoid osteoma. Usually it is present in the concavity of the pathology. It is present inside the pedicle. Of course, opening such patient, and it is young, he is young patient with supraosteal dissection, you can invite fusion, spontaneous fusion, and of course it is typical, nidus in the concavity, no rotation in the curve. It is due to muscle spasm and no compensatory curves. So it is typical osteoid osteoma. So the decision was doing radiofrequency ablation for this patient, which is much helpful for him. The fourth case, it is recurrent osteoid osteoma. This patient he is a dentist, underwent surgery with another colleague in another country, and he came to me with persistent back pain, and there is a lesion, so I decided to do hemilaminectomy, and the previous surgeon did the pediculectomy, so I removed everything, and I decided to fix him in the dorsal spine, and I removed the lamina with the lesion. So my take-home message that think in osteoid osteoma for any case with persistent pain, and perform a small cut CT scan to delineate your tumor. It represents 10% of all benign bone tumors. 25% found in the spine, lumbar spine 60%, cervical spine 26%, thoracic spine 12%, and sacrum in 2%. It is common in males. 25% may have neurological finding, and the recurrence is rare after in block excision. Thank you so much.